All right, good morning, everyone. Can everyone hear me all right? All right, okay. I get this a little more direction. Patrick, we all set? All right, great. Well, welcome to our meeting. It has been a couple of months. I see some people have gotten some haircuts, and I hardly recognize them. Yeah, thanks for showing up today. As a reminder, there's no food or drink of any kind allowed in here, no water bottles. If you brought one in, just don't even open it while you're here. Afterwards, when we have lunch, please don't bring any of the food back in here. It's one of Sanford Burnham Prebys's rules for us using the auditorium for free, so we don't want to mess with their rules. New year, new logo. So if you haven't seen our website lately, we have a new logo that John Tassi put together with the help of ChatGPT, I believe. Yeah, thank you for joining. I'm Aaron Lamb. Want to give a special thanks to the Sanford Burnham Prebys Medical Discovery Institute for allowing us to use this auditorium. They've been wonderful supporting us for years here. I'd like to introduce the principals of our organization for those that have not met them. Myself, Aaron Lamb, director, facilitator, and president at the moment. We have Jean Van Vliet, our director and former treasurer. Bill Manning, director and video editor. John Gottlieb here in the front row. John, raise your hand. He's our treasurer. Steve Pendergast, our secretary and newsletter editor. He's also been updating his blog as well that you can access through our website. We have John Tassi, way off in Missouri, as our webmaster, and Bill Bailey here in the front row as well, our librarian. And of course, there's you. Tons and tons of members, not just in San Diego, not just in California, not just in the US, but even around the world. How many are new here today for the first time? I know there's quite a few of you. I think I've already gotten 4 of the newcomer sheets. Did anyone who is new here today not get one of these to fill out? All right, great. I would like to point out that our website has a number of articles and booklets. There is the resources page off of the website. There's also the contact us page. Please go to that link and sign up for our communications. You don't get a whole lot, but you get announcements about this meeting every month, the newsletter when it comes out, special events such as the UCSD Patient Summit recently. It is the best way to ensure that that you'll get that information. This paper method, I sometimes can't read an email address. So please go there and sign up directly yourself. Now, we're going to do a couple little surveys. This is especially useful for those of you here for the first time that especially might have been recently diagnosed, trying to decide what new therapy you might want to get information on. The thing to do is look around, see who's raising their hand, get an idea for what type of therapy they've experienced, how long they've been going, and those are the people that you might want to go up and talk to after the presentation's over to help get your own questions answered. So we saw, I think, 4 or 5 here for the first time. How many were there again? Raise your hand. 4 of us. How many have been recently diagnosed? Yeah. And definitely the newcomers. How many have had prostate cancer for less than 1 year? Okay, and 1 to 4 years? Several more. 5 to 10 years? 11 to 15 years? And who's had it the longest? Oh, we got quite a few this month. Wonderful, wonderful. The point of that, too, is that this is not a disease that is going to end your life this year. This is a disease that you can overcome, and you have a long life ahead of you. As far as the treatments that we've gone through, who has, raise your hand if you've been on or currently on active surveillance. That is a popular method. Surgery, how many have had surgery? Quite a few of us. How many have had radiation, whether proton, X-ray, or brachytherapy? who's had ADT and hormone therapy, chemotherapy, very few. Focal therapies, these are fairly popular now, whether it's HIFU, laser, cryo, TULSA that we just had a talk on from Dr. Bragrosia earlier last year. New treatments, whether it's Pluvicto, Provenge, Xofigo. A few of us here have also had those. How many people have recurrence? That's right. A lot of people are here just for addressing their recurrence. And how many are undecided about their future treatment? Everyone's hands could be up here in this case. Now, our support to you comes in the way of our website, our YouTube channel. That YouTube channel has recordings of all of our prior meetings. It is a wonderful resource. Please go and check those out. Our video editor, Bill Manning, has politely put in bookmarks to skip my spiel at the beginning so you can go directly into the doctor's presentations. They are just a wealth of information for you. Our meetings, of course, the third Saturdays of every month, not in December. We also have the newsletter, and I should also mention blog. So the newsletter has kind of become a little bit less formalized, and it's turned into more of Steve Pendergast's blog, Finding New Medical Information. So please do check that out. It's at the same place on the website. And we are looking for volunteers to talk to people, to talk to newcomers, whether they are showing up for the first time here at this meeting or contacting us through the website. So if you are willing to help get information to new people joining the organization, please do let me know that you'd be willing to help out with that. We've been meeting outside of these monthly presentation meetings to guide IPCSG's future. We've been trying to formalize and organize the IPCSG a little bit better, helping to identify what exactly are the tasks that are needed, what's covered, what's not covered, and so forth. Our next meeting is going to be on Wednesday, March 4th, in just a couple of weeks, up in the Carmel Valley area. If you are interested in joining being involved with the future of the organization, helping out in any way, please do contact me for the location. It's a slightly smaller room, so I want to make sure I know how many people are showing up before giving it out the location, but it's basically one of the libraries in the Carmel Valley area. And I should mention, part of the reason for doing this is I actually will be stepping back a little bit from my role in this organization. I've been running these meetings for, I think, over 5 years, since kind of the beginning of COVID. And it's time for me to allow other people to step up, take over, lead in different ways, bring in new ideas. You know, as it is, my treatment history, really ended, 7 years ago? And there's so many new treatments, there's so many new experiences, especially that people in this room have had. There's so much new information out there, new technologies on treatments, that we need somebody that is actively looking for treatment, that is experiencing some of these new things, to help push this organization into researching those and getting that information out to other members. And so, since thanks to my radiation oncologist who's here today, who got my PSA to 0, I don't have that same motivation that a lot of people in this room still have. And that's why I'm trying to take a step back to allow the organization to evolve rather than be a little bit stagnant with me. But you'll still see my face around. However, I'd like Mike and Martin, where did Martin go, to please stand up. These two guys in particular, in addition to Mark McGuire, have definitely been stepping up to help out. They've offered to take on a couple of months out of the year of facilitating these meetings. And so you're going to see more of those guys' faces up here and a little bit less of mine. In terms of the other support that you can get, we've really been pushing the PSA test, of course. There are still doctors out there that are not willing to give the PSA test to basically anybody who asks for it. So there's a very low-cost option through Ulta to get a PSA test if you're looking for that. There's also Promise, which is a free, no-cost germline DNA saliva testing. And you can go to that link to see how that works and be involved with that. Genetic testing is just such a fantastic tool for helping to narrow down the type of treatments that would be appropriate to you. And if you don't do this, you should at least be asking your urologist to run a genetic test for you. I'd also like to promote the YMCA Livestrong Prostate Cancer Therapy Exercise Program. This is excellent for people that are on hormone therapy, because as we know, it's extremely important to maintain your muscle, your bone density while going through that type of treatment. And YMCA offers that program for free. You can basically walk into any YMCA and ask about it. It can be a little bit challenging to figure out who exactly is the contact, but push for it. It's worth doing. Now, to be more formal on our support group's purpose, we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not be substitute for your own medical counsel. And we do need your support. Vlad, John, can I get you guys to pass around the donation baskets, please? We are a 501c3 organization, and so all of your donations are tax deductible. There's no medical or religious affiliation. Our largest costs include our website, advertisings, mailings. Let's see, I think the YouTube channel is entirely free, but we still have to prepare all of those videos as well. So please consider making a donation today. Today especially, you could consider this to be a partial first assessment from a radiation oncologist that you might not otherwise get to have an appointment with in your own insurance plan. These meetings are of significant value, so I hope you recognize that, and I hope you can contribute to help maintain this organization. If you can't give today, you can use the PayPal link at the bottom of our homepage, or send a check to the address shown there. That address is also available on the website. Next month, we're going to have Bill Manning here. He is the Executive Director of the Active Surveillance Patients International, I think that is supposed to say, not patents. He will be speaking on active surveillance, and you might recognize his name. Yes, he is also a director of this organization. And so we're excited to hear about what he has to say there. As for today, we have quite the consortium of radiation oncologists from UCSD. We're going to be starting out with Dr. Mundt, who will be introducing the other doctors. He is the professor and department chair of the Radiation Medicine and Applied Sciences Department at UCSD. But we have, as you can see, a number of other doctors, Dr. Rossi, the head of California Proton, Dr. Rose, Seibert, and unfortunately, Dr. Hopper can't be here today on account of COVID, but Dr. Mundt will be stepping in for a few slides there. So with that, I'd like to turn it over to Dr. Mundt. Go ahead and ask questions that pertain to slides here and there, but if you have longer questions, let's just keep them to the end of the meeting. We'll have everybody come up again to answer some of those. I'll walk around with a microphone at that time. So let's see. There we go, and 5, and just left and right. Great. All right, excellent.
Well, good morning, everyone. It's always fun to be back. We have a radiation update at the beginning of every year, which has been a sort of tradition, I think, for like 10 years now. And it's really interesting and enjoyable because when I talk to a patient, they often say, well, I know that, I know that, I know that. And I'm like, oh, where'd you, oh, from the videos from the meeting. So this is a huge benefit. And if you ever go, if you don't know the website, you can click on and learn a lot from a meeting you can't go to, though. A wonderful addition. So what I'm mainly going to be the moderator, because at the end, we're going to keep our talk short. And then we're going to put chairs up here and we're going to just take questions. And you could bring up anything you want about prostate cancer. We'd be happy to talk about it. So we're going to have a couple people. Some of them have spoken here before and some have not. And so, so basically this is sort of the big picture. I'm just going to give a little bit of an intro about radiation, and then Dr. Rose is going to talk about actually when not to treat. It's kind of an interesting thing because sometimes in other cancers we don't ever talk about no treatment. Prostate cancer is a special one. You can actually a number of patients you can observe, you can watch, and only treat them if they need to be treated. That's not true, in lung cancer and a lot of other things. So it is a special thing. So we're going to talk about when not to do things. Dr. Hopper was going to talk about brachytherapy or the internal radiation. I ran to work this morning, made some slides on that. So I'm going to talk a little bit about that. And then Dr. Rose and I are going to handle that if anyone wants to ask questions about that during the Q&A. Dr. Seibert's going to talk about novel clinical trials. He's a clinical trials expert of bringing novel, important new things to the clinic. And there's a number of things that he's oversees at UCSD for that, and he's going to talk about that. And then Carl, I think you're going to talk about protons, right? Yeah. So Carl is the director and the longest. I think if you think about it, in his residency in 1990, he was one of the first patients he treated was prostate cancer at Loma Linda with protons. That's 36 years ago, and I think you had done.
It's going to be 35.
Oh yeah.
October 8th, 1991.
1991. So I think he has the greatest experience in the world in treating prostate cancer with proton therapy for more than a generation. It's pretty amazing. And then we're going to do our Q&A. So maybe a few definitions for people who haven't had or know about radiation. We love our acronyms: IMRT, SBRT, EBRT, and I'll talk about a few of these things and just give it. Basically, it's just ways to focus radiation very accurately and using computer science to help us do that. And I'll show you that. And then I'm going to talk about the process a little bit about radiation. So in prostate cancer treatment, there are three main pillars: surgery or prostatectomy, that's a major one; medical therapy, using the hormone ADT, which is the deprivation of your testosterone. Then all the new chemotherapy drugs fall under that bucket. And then the group that we're going to talk mainly about today, but we have to always bring up the other ones because it's often interplays. A lot of you have had more than one thing, and it's good to understand how the different pillars work together. So when you think of surgery, I mentioned, robotic surgery. So robotic prostatectomy, major advance from the earlier methods of an open prostatectomy. Medical therapy has advanced a lot. Using just Lupron was a thing for many years. The FDA has approved a lot of great new drugs for people who have recurrent disease that has come back, or people that have disease that has spread. There's a lot of new drugs. A very popular one is actually a radiation type of drug where it's Pluvicto, and you have radiation attached that goes injected through the body. And then there's the traditional radiation that we talk about, either external radiation with X-rays or with particles, which are protons, or brachytherapy, which just means inserted radiation. So we'll show you some pictures of those things. But the important thing is this is not new. The first patient treated with with radiation for prostate was 1909. So this is not a new discovery. And radiation was only discovered in 1896. So this is 13 years after the discovery of X-rays, which is pretty amazing that it was used. You can either treat it with the only treatment, which is we call definitive treatment, meaning not surgical, you just have radiation. A lot of people go, well, I can't have surgery, so radiation's kind of a fallback kind of thing. No. They're equally effective for many patients with prostate cancer. So you could have radiation or surgery. And the good news is you can have different things. The bad news is you can have different things, which makes it confusing. But the thing is, you don't choose radiation or surgery if you have early curable prostate cancer based on cure rates, because the cure rates are the same. You base it on toxicities. They're very different, and you have to sort of weigh with your surgeon and radiation doctor what's right for you. One person, surgery would be a great treatment. Another person's radiation would be a great treatment, but it's not like one cures you and one is kind of the backseat fallback of it. That's not the case. And many people have radiation after surgery because their PSA can start sneaking up again, and maybe there's some little cells that are left behind that we can mop up, and then we call that adjuvant therapy. We sometimes do that in addition to surgery if the surgery was not enough. There are two main approaches to radiation. External beam, which is basically we lay you on a table and the energy comes through the air. That could be either with X-rays or with particles, which are called protons. It's confusing because they have almost sound the same. X-rays are called photons and particles are protons. So there's one letter different, but they're very, very different. And Carl will be talking about how protons are different than X-rays. Sorry. A big difference is the equipment. On the left is a photon machine, and that is you lay on we call it a couch. It makes it sound comfortable, but it's not. Many of you have been on these tables. They're hard because we have to keep you very accurately in place. We can't have you sagging on a real couch, but it's kind of painful. We call it a couch. And so you're on the table and the radiation machine moves around and treats you. That's the entire radiation machine for a photon. Over here is the radiation machine for a proton. This is only showing part of the whole thing. And in the center, you see a guy standing there. It's like a three-story, can we say? Three-story building, but you don't see all that. That's all behind the wall. What you see is just a room that looks like a regular photon. Some of you have had proton therapy, you don't see this big thing, but it's a whole building that's dedicated to the equipment. When we talk about radiation, an important thing is talking about how you get it. Basically, we call it fractionation, or the number of times you get radiation. When you get an antibiotic, the pharmacist gives you so many pills. They're all identical, and you take them over a certain amount of time. You can think of that with radiation. A daily thing is just like getting a dose of a pill every day. We try to make it absolutely the same. Like the pharmacist makes the pills all the same. We want to line you up perfectly. We want to deliver it the same way every day. And you'll see the therapists and doctors and everyone is working hard to reproduce the same thing every day. It's annoying because they'll be like saying things like, your bladder is not full enough. We need to have you drink some more water and get back on the table. All this seems annoying, but what they're trying to do is make it accurate and the same every day for treatment. Typically, when I went in the field, actually before Carl, in 1989, we used to treat ungodly number of weeks. It was like 8 weeks, all this stuff, daily treatments, small little doses. Today, that's not the case. The technologies are very accurate and very focused, so we can compress the treatment to shorter treatments. So the standard of care for most prostate cancer patients today is 28. So that's 5 weeks and 3 days. That's very different than when I went in the field. Same dose, now compressed. People are looking at it shorter and shorter and shorter and trying to get to 5, 3, and these really short things. But right now in the United States, 28 is pretty much the typical one. And so we can go faster sometimes, but we have to make sure the normal tissues can tolerate. The bladder, the rectum are right nearby, so we have to be careful about shortening, because it's not shorter, lower dose, it's shorter with bigger doses each day. So we have to be careful about how we do that. So the most common I said today is this kind of 5 weeks and 3 day approach. Brachytherapy, I'll save that slide for a second. Oh, sorry about this. Things are going a little wacko here. So radiation, you start with a consult. You see a doctor like any other doctor. You see the radiation doctor. And then if you're going to get treated, you have a simulation. And a simulation is basically a mapping session. You lay on a table, looks like a CAT scan. It takes a CAT scan image, but it's not used to look for cancer or look for things. It's to make sure we know where the prostate is, the bladder, the rectum. We know everything. We program it into the computer. And so from day to day, we can make sure that the radiation is focused where it needs to be and not be where it doesn't need to be. So sometimes before this simulation, you could have a procedure done, and it's called a spacer. And a spacer is basically some gel that's inserted between the rectum and the prostate to push these two organs away from each other. We like that in general because it's a good thing, because if the rectum is pushed away, that helps us protect it. So there's controversy, does it make a difference? All this different stuff. I tend to like it a lot because anything that pushes a tissue away means I can try to avoid it. So from theoretically, I think it's a pretty good thing. The interesting thing is your body absorbs it back over the number of next six to 12 months. By the time about a year later, it's all gone. You won't even have any of this gel inside your body anymore. Then after we simulate, the doctor's homework starts. You go home, you don't have to do anything from that on. We have to then target where we want to treat, and we work with physicists and dosimetry planners, all this staff of ours that helps us determine where to treat and how to treat. And then that's why there's that gap between seeing somebody getting mapped and you don't just start the next day. There's a lot of homework on our part. So usually it's about 7 to 10 days after you get mapped. And then finally, it's your daily treatments, and we want to make them accurate. You meet with a doctor every week, and we talk about side effects. We'll ask you how your urine's going, how's your bowel function, and there's plenty of medication one can take during treatment to get over the temporary side effects of therapy. During treatment, a very important thing is imaging. Dr. Seibert's going to talk about imaging for diagnosis and things, but on the table, we actually take an image to show you where your prostate is and where your bladder and rectum are, and we can move you around. So if any of you have had radiation, you know, you go on the table, there's a little humming, and then the table moves. And what the table is doing, we're outside the room repositioning the table to help accurately return the treatment to looking like on that planning day. And then this stops, and then you can hear the machine, it hums, and then you get off the table. So this image-guided radiotherapy, IGRT, is what we use, and it's very common, standard of care now in the United States. Years ago, it wasn't. We used to just line up to tattoos on the skin and treat a bigger area and hope for the best. Today, we have imaging and we can aim and the computers can help us, the table can move, all these great advancements. Just like the robotic surgery was introduced in surgery, we have a lot of this artificial intelligence and robotics and things that can help radiation be better too. Let's skip this. And then brachytherapy, I'm going to talk a little bit, so I'm going to skip this slide. And then the last thing I want you to know, it's a team sport. Radiation is not just your doctor. In some ways it would be easy if it was just the doctor, but there's a whole back room of people that work with us, the nurses, the planners, the physicists, the therapists are at the machine. I have a lot of people that ask me, are you going to deliver my treatment every day? You do not want your doctor delivering the treatment every day. That would be like saying, you need to take, penicillin pills. Are you going to be the one that's going to make the pills? Are you going to? No, you have a pharmacist that's going to make this perfectly. So we have certified, trained therapists. Day in, every minute of the day, they're treating patients. These are professionals, trained. That's all they do. And they care a lot about doing this very accuracy. So in some ways, these are like our pharmacists. They make sure what we want to happen is done. At UCSD, just in La Jolla, we treat nearly 200 people a day. And you can imagine the amount of work that is. So every 10 minutes, someone's being treated. And you want these professionals doing this, not the physician. So I'm going to go through the different people really quick, and then we're going to just do the presentations and then hold all the questions to the Q&A afterwards. So we're going to start with Brent Rose. He's an associate professor in my department. He's also, as another boss, the chair of urology. He works in La Jolla mainly. He's the medical director there. He trained at a little-known school, Harvard University, on the East Coast. And he is an expert. He treats both protons and photons. So he has a hybrid in that. He's a researcher. He's done a lot of work with the DoD. Department of Defense is a major supporter of prostate cancer research. And it's really important. It's exciting that DoD, we think of that because we usually think of the National Cancer Institute. But the DoD is something that cares about, and now they're caring about breast cancer. So two common things, that a lot more women coming out in the military, and it's really exciting that they're supporters of common, impactful things. And he's done a lot of work through, and so has Dr. Seibert, through the DoD. So he's both in La Jolla in the California Proton Center. His topic will be when not to treat. Dr. Hopper, who caught COVID from his toddler, so he's not going to be here. So I'm going to show just a couple slides about internal radiation. Dr. Rossi, many people know. I've known him for many years. He's a professor at UCSD. He trained at Loma Linda, the first hospital-based proton center in the world. And so he was there when the whole thing was put in. It's kind of fascinating. He's the director of prostate cancer and medical director at the Proton Therapy Center here in San Diego, internationally recognized proton therapy expert. And as I said, probably has more patients treated experience than anyone in the world. Right here in San Diego, it's kind of nice. And he's exclusively at the Proton Center, and surprise, he'll be talking about proton therapy for prostate cancer. Wouldn't that be funny if he didn't? It's like, no, I don't want to talk about that subject. Dr. Seibert is an associate professor in my department. He gathers more degrees. He has a PhD in addition to an MD. And also he had to beat Dr. Rose. He's in the departments of not only radiation medicine, he's in radiology, bioengineering, and urology, 4 bosses. So it's not necessarily a good thing. So he's also the co-director of a center called Translational Imaging and Precision Medicine, which is exciting. It's the use of novel magnetic resonant imaging, or MRI, to really look at prostate cancer in a more sophisticated way. And I think he'll show some of that. He's also extensively research focused. He's in La Jolla, and he'll be talking about clinical trials. I did have a patient request something from me. He said, if you're talking to the group, there's something you have to bring up. It's not exactly prostate cancer radiation. It's connected, but it's not. It's something that affects all of you. He's a prostate cancer patient, and he said it was actually more impactful on his life than what I treated him and cured his prostate cancer. He said there's something more impactful. It's the use of radiation for arthritis, which is commonplace in Europe, but it's not in the United States. It is now. It is taking off in the United States. The Europeans are funny because they say, we'll show you all our experience. We have 80 years of experience in this in Europe, but you have to promise us one thing. Do not say it's new. It is not new. It's been, the first patient was treated in 1910. With this. So it's completely ridiculous that we haven't done it. It's the use of extremely low doses of radiation, only 6 times to a joint. So it doesn't even add up to 1 day of a cancer treatment. So it's just so low, so safe, 80 years of experience, and it's becoming commonplace. Scripps, Sharp, we do it in many different places. You see it, so it's taking off. So I brought this up. It's a little less connected, but prostate cancer patients and their spouses often suffer from osteoarthritis. Ask your radiation doctor about this. And it's 60 to 70% of patients benefit from a very easy and simple thing. So I promised I would do that. So a little off topic, but I think it's connected to what a lot of people suffer. So why don't we move to Brent? We're back to prostate cancer, I promise.
You should, okay, yeah. And then how do I advance?
Yeah. Oh, sorry. Which one is yours?
Yeah. That's a good question.
Oh, what have I done? Sorry, point to it again. Is it?
It was there.
Oh, okay. There we go. You know what the best part of that osteoarthritis radiation treatment is too, is you don't have to fill your bladder with water. And just left and right.
Did you pay him for that plug, Jeff? Sorry, how do I advance?
Left and right.
Left and right. Okay, great. All right. Well, thank you so much for having us, Aaron and the IPCSG. It's always great to be here and talking to this group. It's really a pleasure of ours. And one thing I love about the group is they're just so focused on how to really understand prostate cancer so you can make the best decisions for yourself, because the decision for the guy next to you might not be what works for your specific situation and your goals and things along those lines. So we're going to kind of pivot a little bit. It's interesting. I'm a radiation oncologist. I spend most of my day treating prostate cancer with radiation, but we're actually going to talk mostly about who we can get away with not treating, who is safe to hold off on any type of treatment and do active surveillance. And one thing that's nice about this group, as Aaron mentioned, there's such a spread. Some people have just been diagnosed with prostate cancer. This is all new. Some people have had it for 20 years, and they could give this talk for me if they wanted to, right? So I apologize. I'm going to start a little bit with the basics just to make sure we're all on the same page with things, and then move into the active surveillance towards the second half of the talk. So just the very basics. So prostate anatomy, just thinking about where exactly this is. So you have to know the anatomy because it's very precious territory right down there. You see the prostate. Is there a pointer? Aaron?
One of these might work. Let's see. Is there a rubber band? Let me.
Yeah, it's okay. So you're not probably going to become a surgeon at this point in life, but it's important to know the anatomy because you can see how close this is to very sensitive tissues, of course, right? So it sits right below the bladder, and the urethra, which you
Just push this button.
which one?
Down there.
Perfect. Which is the tube that you pee through, goes right through the middle of the prostate. Of course, there's the penis, which is nearby, and then the rectum. So these 3 organs tend to be the main things we think about could be affected by any type of cancer treatment that we're going to do for prostate cancer. And so we always get this question, so I just like to bring it up. is the cancer the reason that I'm getting up at night to pee? Is that what's causing my erections to diminish? Almost certainly not. Most of the time, those things are caused by just normal aging process. Your prostate gets a little bit bigger as you get older. That kind of pinches on the urethra. That's usually not from the cancer. The cancer comes from a different part of the prostate most of the time. So those things that you're noticing, those are mostly just normal aging. There are times when the cancer can do those things, but 80–90% of the time, it's just a normal prostate aging process. And so people also wonder, what does the prostate actually do? Well, what it does is it creates the fluid that comes out when you ejaculate. And so that's just, it's a reproductive function. If you're not going to have kids, it's not really helping out a whole lot, but it is there to do that. But it also makes a protein called PSA, or prostate-specific antigen. Everyone's heard of PSA, but just kind of background what it is. All of the cells in the prostate are making this PSA. So every guy in the room has some amount of PSA, unless they've had their prostate removed and it hasn't come back. But most of the PSA, if you don't have cancer, is just coming from the normal prostate. If you get a prostate cancer, that cancer starts to make PSA also. So the combination of PSA from your normal prostate and from the cancer will start to elevate a little bit more. And that's how we sometimes use PSA testing to diagnose prostate, or to screen for prostate cancer, or to identify guys who might be at risk for getting it. But it's not great at that. It's okay. It's not bad as a screening tool, but it's actually a pretty good for risk stratification, meaning how aggressive is the cancer. Really good for monitoring your cancer after, either during surveillance or after the treatment. That's kind of where it's best at, actually. So what is a normal PSA? That's the hard part for screening. There is no normal PSA. And of course, the lab test will give you a high or low value, so it'll make you think that you're normal or abnormal based on that, but everybody's different a little bit. Since a normal prostate makes PSA, the normal prostate grows with age, the PSA is actually very dependent on how old you are at the time. And so the labs will often flag a PSA above 4 and they say, oh, that's high. That's a very arbitrary number. And half of guys with a PSA over 10 don't even have prostate cancer. And 15% of guys with a PSA less than 4 do have a prostate cancer, and the PSA is just not elevated enough to detect it. So it's only an okay marker for screening. It's better than anything else that we have, and we should do it, but it's not perfect for that. Okay? So the other problems with the PSA test, just like I mentioned, if you have a bigger prostate, you'll have a higher PSA. If you have some inflammation, that'll elevate the PSA. Also, if you just had sex, had recent ejaculation, had a digital rectal exam, even riding a bike can falsely elevate your PSA. So if you're going to go get your PSA done, watch out for those 3 things on the bottom, because that can falsely elevate your PSA. So just be aware of that. So whenever we have someone who has prostate cancer, the most important part is how aggressive is the cancer, because prostate cancer exists on this huge spectrum. There's probably 250,000 men in the US get diagnosed with prostate cancer every year. And a big chunk of those we never needed to find out about, because the cancer is just slow growing, would have just sat there the rest of your life without doing anything. There are, of course, very aggressive prostate cancers that have already spread to bones and things like that when we first diagnosed them. Those are the ones we needed to find earlier. And there's the chunk in the middle, which are, if we find them early enough, we can treat them, we can cure them, so you don't end up with metastatic cancer. But again, the biggest chunk is people whose cancer is very slow growing, that likely we can avoid doing any treatment on, so that we don't hit those big 3 organs, your bladder, your rectum, and the penis. So we have to know, how aggressive is the cancer? So the things that we think about, how high is your PSA? Anything less than 10 is a fairly low PSA, actually. And over 20 is a high PSA in that grouping. The Gleason score is what the cancer looks like under a microscope after they've done a biopsy. I'll show you a slide in that in a minute. And then how big is the cancer, and has it spread beyond the prostate? And so almost everyone should get a prostate MRI at some point in their staging. Some, but not all guys, can get a PSMA PET scan depending on whether the risk of spread is high enough. And then the other thing that's kind of a newer element that we should always be thinking about is, do we need to do genomic testing on the cancer? And I'll get that into in a little bit more detail in a second, but that kind of tells us what genes are being activated in the cancer, and are they the kind of genes that are involved in spreading, or are they just kind of normal prostate genes that are just involved in doing normal prostate stuff and not likely to cause spread? So that's something that some, but not all guys will want to do genomic testing for their cancer. So I'm sure everyone remembers this event, which was probably the low point of the recent life. So a prostate biopsy, they put an ultrasound probe in the rectum and they put a needle into the prostate from the back. They usually do 12 biopsy needles, 2 from the top left, 2 from the top right, and so on and so forth. But the problem is you can undersample the prostate cancer in about 30% of the time. A couple reasons for that. One, you're just kind of randomly sampling the prostate. And the other is you're doing it from the back. And so you're not sampling the front and you're trying to avoid the urethra because if the surgeon puts the needle into the urethra, you're going to pee blood for a couple weeks and be very mad about that. So there's a couple blind spots in a standard template biopsy. Oops. And so this is why it's so important to get a prostate MRI. And so this, if you haven't seen a lot of MRIs, this is the prostate here. This is a big honking tumor that's growing on the front of the prostate. And if you did your biopsy from the back through the rectum and put some needles up here, you just missed that whole thing. You wouldn't know that you had that big bad cancer there. So you have to get an MRI at some point, ideally before you get your biopsy. It's very important because we don't want to just blindly sample the prostate. We do that too, but we really want to make sure if there's an area that looks aggressive that someone has put a needle into it and looked at it under a microscope and said, is that cancer? And if so, is it a bad cancer? Okay, so the Gleason grading system, we don't necessarily have to go into this if you've either seen it and you know it, or it's too much to learn on one slide anyway. But I'll just say that it's probably one of the more confusing grading systems in the world because there's 3 different numbers. There's one number and the second number, and they add up to the third number. They tried to simplify that by making grade groups, 1, 2, 3, 4, and 5. So we'll often talk about grade groups, but the community hasn't really transitioned. So that just led us to having to know 2 grading systems, which is a little bit harder. But generally speaking, 3 plus 3 equals 6 is the low-grade prostate cancer. There's actually a lot of talk about whether that's cancer at all, and whether they should stop calling it cancer and start calling it a precursor or something like that, because we should almost never be treating Gleason 6 prostate cancer. It has a very low probability of spreading. Some people say it can't spread, and if you had a Gleason 6 that spread, it was because you actually had a Gleason 7, 8, 9, or 10 that you just didn't know because you didn't have an MRI-guided biopsy or something along those lines. So that's the low-risk group that we're usually going to want to be doing active surveillance on. This 3 plus 4 equals 7 is just one notch up. And in the past, we used to say, oh, it's a Gleason 7, you have to get your prostate taken out or you have to do radiation. We're actually learning that a lot of these are not as aggressive as we had thought that they were. I'll dig into that in a little bit more. There's a few things we have to know before saying all Gleason 7s are okay, particularly the 3 plus 4. But we're moving into doing active surveillance on all of these guys to doing active surveillance in some of these guys. And maybe 5 or 10 years from now with a slightly better technologies, we might be saying that these guys should all be getting active surveillance, but we're not maybe quite there yet. So another thing to think about, should you get a PET scan? PET scans are great. PET scans are really good tools. And so if you can see here on a normal CT, this is your pelvis. There's a lymph node there, but you'd be forgiven because most people wouldn't be able to see that until you give that PET tracer, and now it's glowing orange. So it makes things much easier to see. So if you have an advanced prostate cancer, yes, you should probably get a PET scan to make sure that you know exactly where the cancer is. But if you have a Gleason 6 or a 3 plus 4 equals 7, your PSA is not all that high, you're almost certainly not going to see anything on that PET scan. And unfortunately, one problem with the PET scan is every time you've fallen and you hit your ribs, that spot's going to glow, presumably for the rest of your life. And then you're going to get a PET scan and you're going to see something on your rib and get a little bit worried about that, and the doctor may or may not want to biopsy it. So the long and short of it, there's a high false positive rate with these PSMA PET scans. So if you're low or an early intermediate risk prostate cancer, you probably actually don't want to get a PET scan because you're unlikely to see real cancer and you're somewhat likely to see a false positive. But if you have high risk prostate cancer or more advanced cancer, then you definitely want to get a PET scan. This has been a major improvement and a major update over the scans that we used to have. Okay, so we're really going to focus on early stage prostate cancer. Again, low risk or favorable intermediate risk. Actually, I'm going to come back to that if you don't mind. So I want to talk about this really important paper. This is what's called the PROTECT trial. It was published a few years back and then it was updated again with 15-year outcomes. And so this is called the PROTECT trial. If you haven't had a prostate cancer treatment yet, if you're early in your stage of diagnosis, you really should know about this trial. And it's free to access, actually. So you can just Google this and download it yourself if you really want to read the primary literature. Sometimes primary literature can be a little bit overwhelming, but it is it's easy to get if you want it. So what they did, they took 1,600 guys with localized prostate cancer, and these were all detected from PSA screening. They randomized them to active monitoring, prostatectomy, or radiation therapy. Again, in this case, about 70% of those guys were low risk. And so whether we can extrapolate that to the more intermediate risk folks, we're not totally sure. There are some reasons to think that you could, but that's something to remember. I'd like to point out this slide here this is the percent of people who ended up getting some type of treatment. And so if you're randomized to radiation and prostatectomy, they almost all got that treatment that they were supposed to get. But the guys who were randomized to the active monitoring, about half of the guys ended up getting treated by about 7 or 8 years. And you don't really see a plateau, so this just kind of keeps going up. So the point of active monitoring is you're watching very carefully with the goal of intervening when you think you need to, when the cancer is growing or something like that, where it's starting to become a real threat. And so active monitoring is probably, you could almost think of it as delaying the treatment rather than saying, I'm never going to have treatment. You're just saying, I'm not going to have treatment right now while we carefully look at it, but I might end up getting treated in the future. And the reason why you might want to wait, you might say, well, if I'm going to get treated 10 or 15 years from now, why don't I just do it now? Well, that's 10 or 15 years of erections that might have been affected by the treatment or having to wear pads and things like that. So sometimes delaying these treatments can be a benefit as well. So the take-home message, probably the main line from this study is, okay, we had 500 guys in all these arms, very early stage cancer. Did treating the cancer make a meaningful difference in how long people lived? The answer is no, it didn't really, because the large majority of guys with low risk prostate cancer will never die from their prostate cancer. So treating something that isn't going to kill you can't really make you live much longer, right? So in this case, 98% at 10 years and 96.7% of guys had not died from prostate cancer. And with the radiation, 97.7, 97.2, those are all very, very close numbers. So the take-home message is that within 15 years of a low risk or even maybe an early intermediate risk cancer, the chance of dying from that cancer is actually very low. Okay? Do you have a quick question?
Yeah, are these 3+3s or 3+4s?
So 70% of these are 3+3s. Some amount are 3+4s. There are actually even a couple higher grades than that. But yeah, please.
To slightly correct that, because we just published a few months ago.
Oh, great.
We reviewed all the pathology specimens from this trial, and using modern staging, 42% were Gleason 7 or higher. So more than half of these patients were intermediate risk by today's standards. So that's a misconception we left with for a long time, because they were graded in 2000, 2003,
Yeah, I did want to hedge on that a little bit. These guys didn't get those MRIs, so there was some upgrading that would have happened if they had MRIs. They also, the way we grade, so what we called a Gleason 6 back then, we probably would call some of those we'd call a Gleason 7 now, because we've sort of learned that some of the features there are a little more aggressive than we thought they were at the time. So we're a little bit better at grading, and that's caused what we call stage migration. So, so call it half low risk and half a little bit more than low risk. Go ahead.
What about inter-rater reliability issues? When you talk about Mayo, Hopkins, UCLA versus a huge hospital or for-profit health system.
Dr. Seibert, you want to take that one?
problem, and it's not just which center. We like to think that the name of the center means something, and it probably does to some extent, because you have some specialization. But even if you take 2 people from Hopkins or 2 people from Mayo or from UCSD, you might get a slightly different answers. So a second opinion on pathology is almost always a decent idea, and when you're trying to figure things out. And that's a problem that we're hoping to address with AI. So if you digitize the pathology and you use an automated tool, we might be able to get a better answer.
Okay. There were differences, and I don't want to leave you with the idea that there's no benefit to treatment for any of these folks. And it looked like the main difference is in metastatic disease. So if you do active monitoring, again, your goal is to monitor it, intervene before it becomes incurable, you do see almost 10% of guys get metastases. But again, that's not a huge number, and it's a pretty long time. if you do treatment, it's not like it's zero. It's not like treatment is perfect and you wouldn't get it if you did the treatment. It's probably about 5% and about 10% of metastatic disease. So that is the one caveat here, is that, while we watch the cancer, there is a possibility that it could spread. Again, there's the caveats that we do things better now than we did back then. We grade things differently. We have MRIs to monitor. We closely follow folks and things along those lines. But you have to know there is probably a little bit of an increased risk of developing metastases. Why didn't this translate into people dying from prostate cancer? Probably because we have really good treatments for metastatic prostate cancer now. The hormone therapies that we all kind of love to hate really work pretty well. And so when these cancers do spread, you can still put them to sleep for a very, very long time. So even if they were to develop metastatic disease, you could treat it with hormone therapy. Not that anyone wants to be on hormone therapy the rest of their life, but it's there if you need it. So that's something to be aware of. So who's a good candidate for active surveillance? So first of all men with low-risk prostate cancer should be on active surveillance. If your doctor is telling you need to be treated, you probably should get a second opinion. There might be reasons why you need to be treated, but you'd want to hear that from a couple people first, because they might not be as up with the data if you're hearing that you should get treated for low-risk prostate cancer. Then the real question is more, of those folks with favorable intermediate risk cancer, what should we be doing? Should we be doing active surveillance more? Should we still treat folks that are young and healthy and long life expectancies? It's a little bit of a harder discussion, actually. As I mentioned, there's probably a slightly higher metastatic risk, though that's not large, but you probably have to be aware that exists and be comfortable with that. Here's where I would really introduce that genomic risk, and I'll go back to that slide here now. So there are tests that we can do looking at what genes are being activated in the cancer. And the common one that we use here is Decipher, but there's several different ones. This probably gives you additional information about how aggressive the cancer is beyond what the Gleason score, beyond what the PSA are showing. So if you have favorable intermediate risk and you're thinking of active surveillance, I would definitely get a Decipher test or one of these other tests to decide, is this more of the aggressive type of Gleason 7 or more of the low risk type of Gleason 7? And that can help us push one way or the other. And then there's a couple other things that we're becoming aware of, and Dr. Seibert's kind of leading the charge on the cribiform pattern, but there are a few things that we didn't know were all that big of a deal. One was intraductal pattern. That's kind of become very well known that that's a poor prognostic feature. Cribiform is a different pattern. That's just kind of what it looks like under a microscope. You don't necessarily need to know what it means, but it's just kind of a bad marker. And so if you had a Gleason 7, but there was cribiform pattern or intraductal patterns or some of these other high-risk features, you wouldn't want to do active surveillance in those groups. But those are fairly smaller. And realistically, the older we get, the less benefit we'd get from treating any types of cancer, right? So, or any of the prostate cancers. Prostate cancer grows fairly slowly. Gleason 6, Gleason 7 grows fairly slowly. We measure those in years and decades, not weeks and months. So if you can count the number of decades you think you might have left, how fast is this cancer going to grow? It's a hard decision. No one knows. We don't have a crystal ball. But we don't want to hurt someone with our treatments if they don't have 15 or 20 years left for that cancer to become a big problem. And so that's one of the discussions. It's a little hard to have, but it's something we need to think about. Is it really are we really helping you? Or are we doing it just because someone said you had cancer? So a tough question, but something to have a good discussion with a doctor that you trust. And if you do active surveillance, what does it look like? Well, it's typically PSA every 6 months. We'd normally do an MRI yearly. You need at least one confirmatory biopsy. Make sure you didn't miss it, particularly an MRI-guided confirmatory biopsy. And then how many biopsies do you need after that? That's tough. I don't think there's any clear consensus. Yearly biopsies would be too many. No biopsies is probably too few. You typically would follow the PSA, follow the MRI. When there are changes, that could use that to trigger another biopsy. Often people will kind of do a biopsy about every 3 years or something along those lines, but there's no perfect answer to that. Okay? All right, well, that's what I have for today, and happy to take questions. Let's hold them till the end when they get into specific cases, but we're going to do a panel and go through all your questions, okay?
Who's going next?
Guess it's me.
All right.
You was one like a reverse height order, which would you put me last.
And
They-
you just, oh, sorry, just left and right.
Okay, cool. And on the pointer, it's which button?
Little green button right up here.
Okay, cool, cool. Well, again, thank you for the invitation to come back and talk. And it's been, gosh, I don't know, the 6th or 7th time now, but that's cool because it's, you know, the information that we have as you're learning, it continues to grow as time goes by, which is something I always like to remind my patients is that a lot of the cancer game is buying time, playing for time. There are so many different treatments available now for both early disease and advanced disease than there were even a decade ago, that just keeping something under control for a while may be all you need to do until the next medical breakthrough comes along. So something, again, always to keep in the back of your mind, especially when you're dealing with a disease like this where the natural history is measured in years and even in some cases in decades. So I'm going to give a little update on the current status of proton beam radiation therapy in the United States. We're focusing, of course, on prostate cancer. This is a treatment which has actually been available beginning in 1977 at the Harvard Cyclotron Lab. Was our first prostate cancer patient that was treated. But that was in a facility that was never designed to treat a lot of patients. It was a physics lab that was jury-rigged to treat patients very cleverly, and it was used for nearly half a century in that role. But if you're treating 3 people a day, it's going to take you forever to be able to build up meaningful numbers of patients that you've treated, to analyze your results. It just becomes a boutique treatment. And as Dr. Mundt mentioned earlier, you know, I was fortunate to be doing my residency at Loma Linda when they were building and began to operate what was and is the world's first medical proton treatment center, the first facility that was built to treat using protons in a medical environment, essentially an environment identical to what we have for X-ray therapy, with all the same imaging and conveniences and stuff. So we've gone from one facility back in 1990, which is that dot right there, to we currently have 47 operating centers in the US. There's about another 100 plus around the world, but this is where we're at as of late last year. And you can see that we've got these 2 dots here. Here's San Diego, Loma Linda. There's a 3rd dot up here I'm going to be talking about a bit later. And the majority of the centers, though, are actually in the Midwest and in the East. If you're in the DC area, if you're in New York, Eastern Pennsylvania, you have a plethora of choices. And what's driving this expansion is, like everything else in technology, as I'll be showing you in a bit, thankfully, the machines are getting much smaller than where they were even a decade ago. And therefore, they're becoming much less expensive. So you don't need to have, unless you want, a $200 million building and a technology site like we have there in Mira Mesa, but you're able to do this in environments now where a larger community hospital could potentially be installing these machines in the not too distant future. But fundamentally, the reason that protons have been developed as a radiation weapon gets back to one of our favorite acronyms, ALERA. And Dr. Mundt mentioned we like acronyms. Of course, what specialty does not? The Defense Department is replete with acronyms. I had a whole list in the Navy that still kind of rattling around in my head. ALERA means as low as reasonably achievable. This is the bedrock behind all radiation safety recommendations and really radiation exposure. And it's been learned, like a lot of regulations, literally written in blood. We've known now for 100 years that radiation is a double-edged sword. It can certainly cure cancer. It can also cause cancer. It can cause other problems in the long run, which are every bit as deadly as cancer, such as pulmonary fibrosis, if you think of Dr. Spanos, right? Some of the major figures in radiation oncology and other patients that we've had have died of lung problems, heart problems from radiation may have received to cure them 20 to 30 years prior. So everything we do in radiation therapy has also been driven by this idea. If you look at all of our technical advances, how external beam radiation has evolved, how brachytherapy has evolved, it's been driven by this desire to minimize the amount of radiation we give because radiation is not risk-free. So the less of it we can give to somebody and get the job done, the better. It's also why we don't like doing imaging studies just for the heck of it. And it's also why you don't go to the shoe store, like when my parents were little kids, and stick your foot in the fluoroscopy machine to see if the shoe's going to fit you. Minimize that exposure. That is the one guaranteed way to limit the risk of causing a radiation-induced problem. And conceptually, if you look at different ways of treating the prostate or other parts of the body, we have these technologies that keep evolving. This stands for 3D conformal X-ray therapy. This was the standard of the 1990s. And effectively what you were doing, this is when CT planning first came into being, is you were treating the prostate, which is sitting here in the center of this image, with multiple, we call the 4-field box, X-rays, X-ray beams. And where all these beams would intersect, you'd get this relatively decent high dose area. But you weren't able to do a lot to spare healthy tissue, partly because you couldn't find it and partly because you couldn't be that accurate. So you'd be treating the rectum, you'd be treating the bladder, and a lot of other stuff. If you compare that type of dose distribution now to modern X-ray therapy, VMAT, volumetric arc radiation therapy with X-rays, allows you to concentrate that high dose area much more efficiently. Look at this compared to that. Because you're using computer-controlled and delivered treatment to vary the intensity of the X-ray beams as they enter the patient so that you're minimizing the high dose outside the target. The only potential drawback to this, and that's not to say this is bad therapy, it's extremely good therapy, is that when you're treating with X-rays, you have for each beam an entrance and an exit. That's the physical nature of an X-ray. You can't get around that. That's why you have these, dose as you see it. The reason protons were proposed as a radiation weapon, and this gets back to July of 1946 when they were first talked about, is that unlike an X-ray, a charged particle, subatomic particle that has a mass and electric charge has a limited range, a controllable range, and the majority of its radiation effect is delivered at the end of the particle's path. So when Robert Wilson, a physicist, wrote his paper in 1946 and said, gosh, if you could figure out how to stop these particles in a tumor, you could do a lot to further reduce, not eliminate, but reduce the amount of healthy tissue you treat. This should be beneficial. So in the proton world, that's why we do this. The cancer cells could care less as to what building the patient's going into. They don't know the difference. The fundamental damage that's caused is the same, essentially. The difference is how much healthy tissue you have to expose, because you can potentially stop the particles in the target. You still have an entrance dose, but you don't have this dose bath because you don't have to bring in multiple beams to concentrate dose at depth. So if you look at how protons are used in radiation oncology, and we use them for everything head to toe, it's not because there's something magic that only kills the cancer cell. It's because we're trying to take advantage of that physical difference to minimize the amount of healthy tissue that we treat, to try to satisfy that alera that, again, is underlying all of what we do. And if you talk about alera in the context of radiation therapy, this is some quotes from Herman Suit, who was the now deceased former chairman of the radiation oncology department at Harvard. I'm sure Dr. Mundt met Dr. Suit many times. I did. Brent, I'm not sure if he was still around when you were there. I'm not surprised. He was going to the end. He gave a lecture in 2001, where he made these points about radiation therapy and what we should be looking at in the future. And the first is that there is no, these seem like they're self-evident, and they are. It doesn't hurt to repeat them. No advantage to treating healthy tissue exists. Anything that doesn't need to be treated effectively shouldn't be treated. We always have to with external beam to some degree. We can't get around that, but our technology is allowing us to do less and less of it. And the other one, number two, you're not going to get direct radiation complications in the tissue you don't treat. Why do we like space OAR? Because you reduce the radiation dose to the rectum markedly, less likely to hurt it. Why are we all compulsive about making sure your bladders are full? It's not because we have some, evil, let's torture the patient idea. It's because when your bladder fills up, it moves away from the prostate. We treat less of it. That's always a good thing. Treating smaller treatment volumes and saying that that's superior is not a research question. We've learned that one over and over and over again. That's why our targets become, or our doses become more tightly confined to the target. And what we should be investigating is the magnitude of the gain to achieve all these, and or the cost of achieving that gain. And that really is where a lot of our trials have been focused in what does it take to get that gain? Can you do it easily, less expensive, or is it some hideous cost in only one place in the world that can deliver treatment that will achieve that goal? So I'm going to talk just about a couple of papers that have come out in the last year and a half, and then I'm going to finish up by showing examples of where the technology is going. And this one in particular, the particle trial, is one that's gotten a fair amount of press, both in the lay press and in the radiation medicine world. This was a phase 3 prospective randomized trial where patients with prostate cancer, mostly low and intermediate risk, were randomly assigned to get either intensity modulated X-rays or protons. And as the years went by, these technologies both improved. The protons went from being what's called passive scatter to a lot of them were treated with pencil beams like we use now. But it is the only prospective randomized trial to date that's been accomplished in this area. And this just gives you some idea of the number of patients. They all got the same radiation dose. We used the spacer as it became available. The median follow-up when this was presented, because it hasn't been published yet in a paper, was 5 years. And we were using the EPIC scoring system, which is a system that we've developed to try to determine toxicity. The primary endpoint of this study was looking at changes in bowel function at 2 years. All right, so a lot of other things are being looked at, but that's the primary endpoint. So the key results, basically no difference, which is good. There was no difference in bowel distress between the patients, and there was no difference in disease control at 5 years. So the conclusion, was not that, as I've seen some physicians saying who should know better, oh, protons didn't work. It's like, no. The conclusion is they're both working very well. This trial demonstrates that they're effectively equivalent, at least at this time point, 5 years. Now, there are a lot of things that happen in radiation therapy that happen beyond 5 years. There are much rarer events like radiation-induced malignancies, but they can also be more devastating. So these patients, of course, are going to be followed for a long time. But the fact that there was no difference in the bowel function score at 24 months doesn't mean that you suddenly have to abandon either technology for treating prostate cancer patients. It's a good sign that they're both very effective treatments for this disease. And I had to give a little talk on this about my comments on the trial, which I'm going to go through. And it really gets back again to Alera. What about Alera in the context of this trial? So there's some pros and cons to the study as well, like there are in every clinical trial we've ever done. The good thing on the pros, this is a true prospective randomized trial, but not just between protons and X-rays. It's the first prospective randomized trial between external beam technologies. What I mean by that is our standard radiation therapy now is intensity modulated X-ray therapy. Great. We had other things before that, like 3D conformal X-ray therapy. But if you look at the history of intensity modulated X-ray therapy coming into clinical use, it didn't become suddenly clinically used because there was a prospective randomized trial saying, oh, look, it's better than 3D conformal, or the same thing is true with 3D conformal. It didn't become used because it was better than cobalt-60, based on a randomized trial. These other technologies became used and became generally accepted because their physics was superior. If you look at their dose distributions, they're better, they're tighter. It's satisfying that Alera goal again. So this is the way radiotherapy has progressed. Now, this is actually the first time we've looked at these two different technologies and said we have to do a randomized trial to see if there's a difference. We now have that level 1 evidence saying the protons and IMRT are equally effective, which is important because you have some retrospective studies generally based upon doing database mining saying, oh no, there's more toxicity in one versus the other. And I think most importantly, you can reassure your patients, look, they're both really good. Again, it's not that one is bad and one is better. They are both apparently equally well effective and they are equally well tolerated. The downsides are the relative cons. First of all, the patients in this study were the group that were least likely to benefit from the differences in the radiation dose distribution. What I mean by that is these were patients with low and intermediate risk disease. We're treating a small, roughly spherical target. That's a good thing to treat with either of these technologies. If you look at protons and the dose distributions in general, the larger the area you have to treat, like say you have to treat the whole pelvis, and the more irregular the shape, the greater the disparity in dose to normal tissue. So if you look at other patient populations, you may see a difference because you're now treating bowel in one case and you may not in the other. You know, second, the primary endpoint, bowel toxicity at 24 months, well, yeah, that's important, but that is a very short time in the radiation oncology world. And there are a lot of other events. I mentioned second cancers, changes in bladder function, et cetera, that occur at farther down the road. And even though this patient population may not live for 30, 40 years, some of the stuff can become an issue at 5, 10, 15 years. And ALERA is still important. That hasn't suddenly gone away because we have one study saying we had equivalent toxicity in one domain at 2 years. It comes back to getting the cost of the treatment to be equivalent, which in many cases it already is, and the availability being equivalent, and which allows you potentially take advantage of the using protons to get closer to satisfying this ALERA goal. And that was the conclusions that I had. And it's something that still continues to drive all of our technology advancement, as it should. We want to try to minimize the amount of healthy tissue that we treat until we get to the day where we don't have to treat any at all. And by the way, brachytherapy, that Dr. Mundt's going to be talking about, does an excellent job of sparing healthy tissue. So a couple quick papers. Dr. Mundt mentioned hypofractionation, this idea of treating in 4 to 6 weeks versus the 8 to 9 weeks that we actually used to do at Loma Linda. There's a paper out of one of the groups in Japan, which was looking at hypofractionation and basically saying that it works in the proton sphere, just like it should. It does work in the X-ray therapy world. No surprise there at all. Here's another paper, same idea, but looking at reviewing the data that's out there, doing a meta-analysis, saying that there was, again, in a retrospective analysis, lower acute GI toxicity in the proton patients. There was a slight improvement in biochemical relapse-free survival at 5 years. That's pretty minimal. They saw that benefit across groups, and their caveat was this was a heterogeneous study pool. But I look at these numbers, you can't nitpick them. You can say they're both, showing that protons and X-rays are equivalent treatment, and that there are some potential differences in the toxicity profiles. Now, the patients that may benefit more because of the dose distribution are the folks who need to have their pelvis treated. And this is the first decent paper I've seen that has looked at that patient population. This comes out of the Mayo Clinic group, where Mayo Clinic currently operates now 3 proton centers in the United States, so they have a large patient population to draw from. And effectively what they were saying is that they saw very little late toxicity in the bowel sphere or in the urinary sphere in these patients, despite the fact they were getting their pelvis treated because they were able to reduce that dose to the other pelvic organs versus IMRT by taking advantage, again, of the physics and not having to treat as much of the individual. So if you look at where we're at, take that 30,000-foot view. We've got the meta-analysis saying that we have a safe and effective treatment, that there, in general, you potentially have some toxicity advantages. You've got the payers that are all over the place on this. You have some payers that classify it as not medically necessary. By the way, this same payer, Carillon, says that 3D conformal X-ray therapy is acceptable treatment for prostate cancer with external beam. They do in their latest policy. So they're telling you that what we did 30 years ago is just as good as anything else. Great. I'm glad to hear it. Wish I'd known that 30 years ago. This is where we're seeing the changes. You always hear about, the cost it's 2 times. I hear all these different figures from people who've never done it. 2 times more, 5 times more, 10 times more, et cetera, et cetera. Cost is something that, first of all, is going to be determined by your contract. We have contracts, as do other proton facilities, with certain insurers where the cost of the payer is the same whether we treat with protons or X-rays. That's just the way it is. It's a negotiated, you negotiate a contract. But what's really going to help to drive the cost down lower is that we're getting away from this needing several hundred million to build a facility with 30-foot gantries like the picture Dr. Mundt showed you earlier, to where we're now getting machines that effectively fit in the same space as a standard medical linear accelerator with costs that are quoted by the manufacturers to be in the range of what we pay and for building, a modern X-ray therapy facility. And there are a whole bunch of trials, in the scientific world that are going on, including COMPARE, which we're participating in here, to look at to look at our treatments over time. And there are many other technical developments that are occurring to try to further optimize how protons are delivered. So, smaller centers. The first one that is either operational or about to be operational, I haven't heard they've treated a patient yet, is this facility up at Stanford. And they're using a company called Mevion, which is one of the major manufacturers now in the proton world. And they have actually, and I'll show a picture of it in a second, installed this in a room that used to hold an X-ray therapy unit. And this is just a slide to give an idea of the timeline. They made a decision in 2022 to do it. It took them, about a year to prep the room. They have delivered the equipment. They installed it. And when I was up there in late September, they were in the process of commissioning it. That's blazingly fast in the proton world compared to, if you look at our timeline here in San Diego, construction started 2010, treated first patient in early 2014. They give some another example of how the room is laid out, but more importantly, this is what it looks like. And this is not a picture from the manufacturer. It's a picture from my iPhone. I took it when I was there at the end of September. So what you have is you don't have a big gantry that come in from any angle. You actually do what they did at Berkeley back in the 70s and 80s. You have a patient, and even before that with X-rays, this is a chair that is mounted on a turntable. So the protons are coming out of this black nozzle here, and it's a scanning beam nozzle. This chair is not just a chair you sit in. It can do this, it can do this, it can raw pitch and roll. I mean, you're going to put people, for some of the things they're going to treat, you're going to be in a very uncomfortable position, but it lets you compact the machinery. And this donut you see up here is a CT scanner that's used for image guidance. It, kind of comes down like the old cone of silence on Get Smart, if anyone remembers that. Hopefully not the same result, but that's how it works. So this is what used to be a tomotherapy unit in this room. Very, very nice. And that's the accelerator, right? We have we use a cyclotron over at our center, which is 3.2 meters in diameter. I put my arms around this thing. It's about, and I'm not exactly a big guy. It's about like that. And how can they make it that much smaller than what we have, which is much smaller than most proton centers? It's a superconducting machine, and it's using a 9 Tesla magnetic field to really be able to squeeze that racetrack. We accelerate the protons out into a small area. So, you start getting things like this, and this just parallels the history of X-ray therapy development. Now you start to have machines which are potentially installable in many, many, many more locations. Or, if Stanford does it, UCSF is not going to allow themselves to be left behind. It's like, Ford and GM. UCSF is building a multi-room proton center in downtown San Francisco, actually on the water. They broke ground about 6 months ago. It's going to be more or less a copy of what we have here, and they're hoping to treat their first patient in 2029. So there's still a role for the bigger facilities, but the one-room centers have represented the majority of the growth in protons around the world in the last couple of years, and that trajectory appears to be continuing. So if you wrap it all up, proton beam therapy is one of the many effective treatments for prostate cancer. Thank God it's not the only one. I'm not the only person in the world who can treat prostate cancer, and thank God about that. It's one of our many good treatments, and all of our treatments are getting better. The technology is continuing to improve, like all technology, like your cell phone, like your laptop. These things are all getting better, smaller, cheaper, et cetera. And as that happens, we're going to get to the point where the cost of treatment is going to further, it's going to converge with the cost of X-ray therapy, which will make it more appealing to the various payers. And I'm already seeing that. That's been a trend that's been going on for about the last half decade or so. And that's up in northern Queensland. It was a fun day. Thank you very much.
Where did you say this was again? This is
That is a place called Hell's Gate Roadhouse. It's in far northwestern Queensland, and that's the runway. We landed on it in Australia. Yeah, so it's up here.
He's a pilot.
nice.
That's his run.
Yeah.
Which one is yours here? Is it this one here? All right, excellent. And you saw left and right.
Or is it covers minutes? It depends how you talk. It's talking about a cure that covered it since 1991.
All right. We're getting toward the end, so I'm going to try to go a little bit quickly so you have time for questions. I know that's a popular part of this. I'm grateful to be back. Probably some people I recognize, and I see lots of new faces too. I'll talk about new things that we're doing to try to figure out how to make stuff better, right? You've heard about PSMA PET scans and MRI and how we can maybe find cancer and things, but how can we use that to make people's lives better? So next generation scans can help us to see cancer better. And what we're trying to do is figure out how to use that to change the way we treat the disease, with the top priority of trying to make a meaningful difference for patients. And I'll talk about 3 clinical trials. And before I get to that, I'm just going to do one, because you've heard like 4 times now today, somebody has mentioned filling your bladder. I'm an engineer by training. That was my PhD and my undergrad degree. I'm not convinced at all on the evidence of filling the bladder. So we are also running a clinical trial right now comparing full versus empty. So a pitch, if you're planning on getting radiation anywhere else you go, you're gonna have to fill your bladder every day. But if you come see us, you got a 50% chance of getting to have an empty bladder. And you'll contribute to changing the way this is done around the world, because I think this is going to work, and we're just going to stop doing the full bladder thing, but we'll see. So the first trial relies on understanding one that was done before us in the Netherlands. So this was called the FLAME trial. The way that we treated prostate cancer in the old days was treat the whole prostate. Remember, you're either removing the whole thing or you're treating the whole thing. Why do you treat the whole thing with radiation? Well, when they started doing it, you couldn't see where the cancer was anyway, so you had to treat the whole prostate. You know it's in there, and you don't know where in there it is. That PROTECT trial that Dr. Rose was talking about, they were doing old radiation. They could not see even where the prostate was every day when they were treating, let alone where the cancer was within it. So a full dose to the whole prostate has been the way we've done it from the beginning. And in this image, yellow is full dose. So this is a 28 fraction treatment. It's not important, but yellow is the full dose. And then green is kind of a low dose around it. And what they compared in a randomized trial was they said, you sign up for the trial, we won't tell you which group you're in, but you're either going to get the full dose to the whole gland, the whole prostate gland, or we'll do the full dose to everything except we'll increase the dose to the tumor we can see, because now we have MRI, we can see where the tumor is, and we'll give it a boost. So they had a focal boost, and they compared these 2 groups. The patients didn't know which group they were in. But what did they find? The focal group had 1/3 of the chance of the cancer coming back in the prostate, 3 times less. It was about half as likely to spread to another part of the body. So huge win for the group with the focal boost, right? And no difference in side effects when we asked patients how they were feeling, well, the investigators then. So how do we build on that? First of all, that you should know is not commonly done, even though it worked really well. It's technically challenging, so it's not commonly done in a lot of places in the United States. It's probably about 10% of patients that are getting that, they undergo radiation. If you're seeing us, that's everybody gets a focal boost where it's achievable. So how can we do better than that? Well, an important thing that they found on that trial is if the cancer came back in the prostate, and remember it was 3 times less likely if you got the boost, but in both groups, if the cancer came back, where it came back was where it was in the first place. Right? Some cells survived and then they grew back, which makes a lot of sense, right? It didn't just grow back in some other place, it grew back where it was. But that begs the question, well, if I know where the cancer is, and I know that increasing the dose there helps, do I really need to go after everything else so aggressively? So that's this trial, RAD target. This is standard radiotherapy. We do full dose to the whole prostate plus add a little margin, a few millimeters, to make sure that you're getting anything that's spread around it, and because it might wiggle a little bit inside of you while we're treating you. And we give this focal boost. That's the standard group. What about tumor-focused radiotherapy? This is our experimental arm. This is what we're trying that's new. We do a boost. We add a margin around that boost of a few millimeters. You see that pink line. That gets full dose. So just to be safe, because you might be a little inaccurate, maybe. And everything else gets a low dose. Not zero, because there still might be some low-grade cancer there. It's possible. But we don't think there's anything aggressive there, or we would have seen it on the scan. So we'll do a low dose, and that will decrease the dose to the bladder, to the rectum, to the urethra substantially. So here's that flame again, full dose versus focal boost, and here's RAD target. Now the red is all around the cancer, and the whole rest of the prostate is just getting that low green. Right? Enough to kill microscopic disease, the same dose that we give to lymph nodes, for example, when we don't know that they have cancer in them, just to be safe in patients with very high risk cancer. So it's not nothing, but it will lower the dose to that prostate, to the rectum and the bladder substantially. And part of the reason why we feel confident that we can do this is because we've also developed a more advanced form of MRI, this RSI restriction score biomarker that, as you can see in the lower left, makes the cancer really easy. Prostate MRI is hard. We talked about having 2 different pathologists look at your tumor and they may give you a slightly different answer. Having 2 different radiologists look at your MRI scan might give a very different answer. Prostate MRI is hard, but we're trying to make it easier. Again, engineering, right? How do we make things quantitative, objective? Everybody in the room can see where the tumor is on the lower left, and none of you are probably radiologists. So the trial is randomizing patients to either standard radiation or tumor-focused radiation, and then we'll compare the outcomes, and this is ongoing. Now, high-risk prostate cancer. A lot of patients with high-risk prostate cancer get radiotherapy, radiation. And when they have high-risk prostate cancer, it's not spread already. This is cancer that's in the prostate, but that has appearance of being aggressive and could spread. So we call that high risk. We give radiation and 24 months, 2 years of hormone therapy, ADT, which a lot of you have experienced. And if you've experienced it, you probably understand why 2 years sounds like a long time to be on that. And it's 2 years plus recovery time, which could take another 2 years. So it's a pretty strong impact on people's lives. And we're wondering if we can do something better. So it has a major impact on people's quality of life, especially if it's for a long time. It works. We don't do it for fun. We do it because it saves people's lives. But again, wondering if we can do something better in the modern era. So if we only gave short-term hormone therapy, 6 months, instead of 2 years, what would happen? Because that's what we used to do before the trials came out showing that 2 years was better. What happens if you only do 6 months? Well, most of the patients are cured. All right? So there's no benefit to them of doing longer. Those ones are great. But some are going to have the cancer either come back locally, meaning in the prostate, and some are going to have it come back somewhere else in their body. So the question is, if you gave them, instead of 6 months, you gave them 2 years, would that have cured those people? Or would it just have delayed detection because the hormone therapy drops your PSA to like 0, right? So you can't tell if the cancer is growing back or not. So you may either have been cured or we just kept it hidden for a while, right? We're not sure which one of those things happened. So here's this trial. This is called the Century trial. We're giving patients, we're testing a hypothesis that if you give people short-term, 6 months of hormone therapy with their radiation that have high risk, majority will be cured. Some will have the cancer come back because it's resistant. It survives. Some of the cells survive that radiation. Some could have it come back because it already had spread before I started treating you. It was already microscopically in, say, your lymph nodes or in the bones. But we have some things we can do about that today, all right? Both of those would lead to lifelong hormone therapy, which is what I'm trying to avoid. So this is the pathway, right? If you're cured, great. If you have it come back, you could end up in the lifelong hormone therapy, and that's what I want to avoid for people with high-risk prostate cancer. So we have focal boost. That helps decrease the chance of the cancer coming back in the prostate substantially, like we showed. We also have, if it comes back in the prostate, we can do radiation again, which you may have heard you cannot do. That's old talk. We now can do radiation again if it comes back because we have higher precision, higher dose radiation. If it comes back in some other part of your body, instead of starting you right away on hormone therapy, we also have the option of spot treating the places it came back. If it comes back in 3 bones, we could treat those and delay the need for hormone therapy. We also use MRI and PET scans to better select patients up front. And we use PSMA PET scans where we could to find those spots if it comes back so that we can treat them earlier. And we have additional medications that we can give with the hormone therapy. So maybe make it more intense during that 6 months, but shorter. Because adding a second medication during those 6 months adds some side effects, but not nearly as much as being on the whole thing for 2 years, plus recovery time. So here's the trial. In both arms, we're actually shortening a bit the hormone therapy duration. So we're either doing 18 months instead of 24, but that's within the realm of kind of standard, or 6 months. And in the 6 months group, you have the option of adding a second drug. That's going to be a discussion with the patient. And then we do something that is new and different, which is we're going to do a PET scan every year after treatment, which you can't get paid for by insurance. So this is an agreement with the company that I've negotiated so that we can do this specifically on the trial. Most patients, we hope, will have no visible disease. We'll just check their PSA, we'll get the scan, they're all doing well, nothing to do. We just keep watching them. Some could have the cancer come back in a few spots that we identify on the scan. And for those, we'll do radiation to those spots so that we don't have to put them back on hormone therapy. And then the worst outcome, of course, which unfortunately could happen but is rare, would be widespread metastasis that we say, you really have to go back on hormone therapy. That's what we're trying to avoid because it leads to lifelong hormone therapy, right? So that's what we're trying to avoid. And my hypothesis on this trial is that whether you get the 6 months, maybe intensified, or the 18 months, if we do this yearly scan and we follow you closely and we do radiation, if it comes back in a few spots, we will have no difference in the number of patients who go on lifelong hormone therapy. But all the ones in the short-term arm will have better quality of life because they didn't have to be castrated for all of those years. Lastly, and very quickly, what about patients whose cancer has already spread? We also have a trial for you. If we can see where the cancer is and it's 10 or fewer spots, then we're randomizing patients to either getting your standard systemic therapy. So this is patients who need medication of some kind. You get your standard systemic therapy plus radiation to all of those spots, or just the systemic therapy alone. That's the test. This is for actually any kind of cancer, prostate or other, and that trial is ongoing. We'll have 300 patients enroll. So I'll stop just to say that clinical trials are extremely important. This is how we find out what's better, not just what we think might be better. And if we work together, you and us, we can bring you tomorrow's treatments now, and you can help to make tomorrow's treatments faster and more quickly available to everybody in the world. And thank you so much for your attention.
Dr. Mundt, did you want to do the hopper slides? That sounds good. I've got another microphone up here. I'm a little bit speechless here at the moment. I'll explain why in a second. But another round of applause, please, for these guys. Really fantastic information. I kind of got caught up in the middle of what Dr. Seibert was saying, because just as soon as he said, yeah, we can go back and do radiation again if it comes back. It's like, well, that wasn't the case 8 years ago when I got my radiation. I was making a decision back then, is it time to do radiation? Because you got one bullet and you either use it now or you use it later. And I mean, how phenomenal that you can't just do radiation one time, and that it could be useful again and again. So the new technology that these guys are coming up with is just amazing. So consider that. Thank you.
All right. And Eric, can we do a projector? I think it's shiny.
Yep.
Like where it is.
Thank you for that.
So let me see if I have one more microphone.
So as you notice, I skipped the brachytherapy thing, so I'm going to give like 60 seconds on that. And it's internal radiation, where we put radiation either temporarily or permanently into the prostate. The ones that are permanent is called low dose rate brachytherapy. That was the standard for many, many years. Today, the temporary version is called high dose rate brachytherapy. That's the one, if we're going to do brachytherapy today, that's one we want to do because we can avoid the urethra. And the urethra is, again, the tube that goes through your prostate that takes your urine out your body. That's the one that the patients for a couple months, actually 3 to 4 months, are miserable after low dose rate. High dose rate, we can sculpt it around and patients do a lot better. You used to have to go to Los Angeles to have, if you were going to have brachytherapy, and we would treat at UCLA. Today, we've started 2 programs back at UCSD. We're starting one in Hillcrest, and we also, many of you might know from the press, UCSD is merging with Palomar Hospital on I-15. And so we're going to be running the cancer program up there. They started a HDR program with a physician that I'm going to bring next year. But I'm really excited. There's no more need to go to Los Angeles for anything. We have protons. We have anything you want in San Diego, which is exciting. So let's now flip to the questions and answers. Hopefully answers.
I'm going to run around with the microphone.
We'll have Aaron moderate.
Thank you. By the way, all the presentations were really phenomenal. Thank you. I'm on active surveillance and I get MRIs done regularly. How critical is the gadolinium contrast agent and can I opt out of that?
Yeah, so my PhD is in MRI, and I lead a program on prostate MRI, which is how we got to those trials. This is something that we look at a lot. I'm actually running an international trial right now comparing with or without the gadolinium, not for active surveillance, but for the initial diagnosis. It depends. Like most patients, it's going to be fine without the gadolinium. There's not much benefit for the vast majority of patients, but occasionally, maybe 10% of patients, it will make a difference. The other thing is that if you do it without the gadolinium, the radiologist will definitely complain. They will always say in the report, well, I don't know for sure because I didn't have the gadolinium. Like you've deprived them of the opportunity to look at it all of the best way. And so that will always be in the report and you'll be made to feel guilty for not having it. And I will be made to feel guilty for not ordering it. So, but will it make a big difference? Most of the time not. But there's there's a trade-off. It might have made the difference for whether you get a biopsy or not, but probably not.
Does it have any effect on the PRAD scale?
Well, to do a full PIRADS report, you have to have the contrast. There's a cheat for doing it without the contrast, but they will always put a caveat in there and say, I can't do this correctly officially because I didn't have the contrast.
Okay, here's a quick, stupid question. You have your prostate out 23 years ago, okay, and then they did some radiation because there was still a PSA, but there was still a PSA after that, and so they took your testosterone away for years, and then that stopped working, and so they put you on a pill, okay? And the pill I'm on is Xtandi, okay? Now, here's my question. Is there a way now to find, so someplace those prostate cancer cells are still around, even though you don't have a prostate. Is there a good way to find those now?
So the best way currently would be to do a PSMA PET scan. The best way now is a PSMA PET scan.
PSMA.
Yep, a PSMA PET scan. That will often show spots of cancer. The downside is it likely won't show all of the cancer in your body.
You mean those little cells could be all over?
Yeah.
And the pill takes them away for a while, or what?
The pill is sort of like a stronger version of the testosterone suppression, like from the shots, like Lupron. Adding the pill is another way to block the testosterone signaling. And so what that's doing is effectively making the cancer cells go dormant. And so you can't eradicate them with that pill, but you can make them dormant with that pill. Yeah. If you were to get a PET scan, you might find areas of cancer that you could consider doing focused radiation like SBRT or Seibert to those specific areas. We don't think that we can cure the cancer that way once it's spread to bones and things like that. So the goal would be, is it one more tool to use in the toolkit to keep targeting your cancer? But every case is very different, and the quality of data on how effective that would be for any one person is a little bit mixed. And one of the reasons that Dr. Seibert is running some of these trials that we talked about.
Thank you all for being here. Quick question. I had prostate surgery about 5 years ago. I was non-detectable for about a year. And then after that first year, pretty steady climb. My most recent test was 0.32, which is pretty much biochemical recurrence. My question is how, and my doubling time was about a year and a half. How realistically, how long can I delay any treatment, radiation, especially hormone therapy, which I'd like to steer clear of both. But just your opinion on realistically how long I can delay based on that info. Thank you.
So the evidence that we have is we used to treat everybody who had any PSA come back after surgery. And then there were 3 randomized trials that were done at the same time, comparing right away treatment versus waiting until about 0.3, 0.2 to 0.3. And they showed that on average, patients who waited till about 0.2 to 0.3 had less side effects in the long run because of that time for recovery, and weren't any more likely to, say, die from prostate cancer or have it spread to somewhere else. So what we can say is that waiting until about what you mentioned is generally safe, depending on the details for any given individual. Waiting beyond that, we have no idea. So, no specific advice for you, but generally I tell patients when you get to 0.2 to 0.3, it's time for treatment.
There's some fairly low quality data suggesting the higher the PSA is, the less likely you are to cure it with radiation and hormone therapy. There's a lot of reasons why that might not be perfect, but we do worry a little bit once we get past that 0.2, 0.3 number that we're losing the opportunity to cure the cancer. That being said, for any given person, there's absolutely no way to know. So it could very easily be fine to wait, and especially with the slow doubling time and things like that. But it's hard to give a recommendation as a doctor that it's okay to wait, because we do have some data suggesting that the best chance to cure it is right now once you're at that 0.2, 0.3 range.
And the higher the PSA, the more important the ADT is, the hormone therapy. So if the longer you wait, the more uncomfortable we would be doing radiation alone.
But it's not an emergency. So, but I think you've come to the time that something should be done, but not like Monday, it has to be done or something. But I think we probably shouldn't continue with watching the PSA. We probably should have you talk to someone. Okay.
2 questions, if I may. Dr. Mundt first. I'm very interested in the radiation for osteoporosis.
So my patient was right.
I'm kind of a candidate for a knee replacement.
It's great to have a patient-oriented group to have a patient. So I was like, Aaron was like, you have to listen to the patient, but okay.
So would it work with bone-on-bone?
Less likely on bone, but it can work on bone.
Okay. All right. Second question for Dr. Rose. Is there a way of getting Gleason score without a biopsy?
No. Yeah. Unfortunately not.
The wrong answer.
Yeah, I know. You'll probably hear things, more and more these days about liquid biopsies where they take a blood sample and try to identify cancer from a blood sample. They don't tend to work very well for prostate cancer, so the sensitivity of detecting those cells is not very good for prostate cancer. In other cancers, it might be a little bit better. And the idea that you could get a Gleason score off that is unfortunately not the case. On MRI, they give you a PIRAD score on the MRI, which is not a Gleason score. So what that is how likely it is that there's cancer there. So you can't kind of substitute a PIRAD score for a Gleason score, unfortunately. So you probably have to bite the bullet.
Our biomarker for advanced MRI gives you a probability, or we can use that to give a probability of each grade. So it's getting you closer to that. And it can tell you that you're very unlikely to have any significant cancer, so you don't need a biopsy. But before treatment, you still need a biopsy.
I'd like to, I congratulate you for bringing the latest research to us. But my concern is which of the studies behind that progress are longitudinal studies that have been supported by NIH, NSF, DOD, all who have had their funds cut, and in some cases, further interference for certain kinds of research not being supported any longer. Can you comment on this, and what is it doing to the research that you depend on?
Yeah, that's a fantastic question. So all of the research that we do is funded by mostly these governmental agencies, some foundations and things along those lines. And it's so critical to be able to make things better. And unfortunately, there has been a lot of cuts and a lot of talks about cuts on the research budget nationally. And that has affected research in many, many ways. Some ongoing trials have been threatened. Tyler, have you had any issues with that with your research?
Yeah, the pipeline for new scientists is really under threat right now. So the current generation of graduate students is struggling to find mentors that have the funding to support them. So we're really hurting, honestly, and we're putting ourselves in a position where we need to rely on other countries that haven't made this decision. So for what it's worth, as a cancer support group, whatever your influence you have to help encourage better funding for cancer research, I think is important. And then we also have to be creative. So we try to find ways to get things done with less support. And we rely on philanthropy. So people who are in a position to help with fundraising and donations to our institution or others or to foundations. Dr. Rose and I in particular, we've had a lot of help from like the Prostate Cancer Foundation, for example. So we do our best.
We're blessed in San Diego that we have a representative, Scott Peters, and others who are very supportive for research. But it also, I think, behooves a lot of us in academia to be better stewards of money. And so we can team up with the government, keep the funding, but show that we're using it, appropriately and wisely. And I think if that type of thing, the Senate across the line, Republicans and Democrats are supportive of cancer research, because that's something that in the United States has been a very positive thing. But I think we need reform on both sides, and I think we can do it together, but not have it disappear. That's not doing anything. But if we do it, we could come out of into a better world afterwards.
My question is really a follow-up to the one we just had on biochemical recurrence following surgery. My understanding is the standard of care under that circumstances is to kind of bathe a fairly broad area, and the real issue is side effects associated with that. My question is, based on what you were just talking about or other things, is there technology or advances or trials that are looking at how to be more focal in that circumstance, given that, at least initially, the cancer probably is in a relatively small place if you can find it? Is there research going on where you can intervene earlier in that 0.2 to 0.3 range, but at the same time minimize the potential for side effects?
Yeah, there are some trials. We had one open that has now finished accrual, so we're waiting for the results. And there are a couple of others that are basically all trying to look at the idea of, if you use PSMA PET, can we use that to guide where we should treat, how big of an area do we need to bathe, as you say, and I think those are promising. You still have the problem that with very low PSA, usually you can't see anything. But now with PSMA PET, sometimes you can see something. So we are getting, we are getting better. I think deciding whether we need to treat the lymph nodes, for example, makes a big difference in risk stratification. The genomic test that Dr. Rose was talking about can help perhaps with that. So it's getting better.
One thing I'll say though, the PSMA PET is good, but it's not perfect, particularly for small amounts of cancer. So if you get a PSMA PET and your PSA is 0.2 and they don't see anything, that tells you that you're not seeing all of the cancer. So sometimes we come to this idea is, well, let's just wait until the PSMA PET shows me the cancer. The problem is you could wait and your PSA get up to 1 and you get a PSMA PET and you see something, but you're still not seeing all of the cancer. So if you wait until you see something and treat that something, there's almost certainly going to be other cells out there that you can't see. So in this case, you still have a really good chance of curing it. If you wait until you see something on the PET scan, all you really do is lose the chance of cure because you're still not seeing all of the cancer. So it's a little bit like fool's gold because you think if you just wait till you get a PET and you see something, you can target it more. Unfortunately, with our current tools, I don't know that that's going to work. I think the next generation of tools, we're going to need the next generation of tools to do that, and we really wish we had it.
And I just want to clarify that when I was talking about this Century trial where I said we'll watch and we'll do PSMA PET scans and we'll see if it comes back, that's because I'm talking about metastatic disease, right? So it's different. I think if you're in this low PSA post-surgery, we want to take that last chance to cure. Right? The first try was the surgery, didn't quite get the job done, but radiation might finish that job. Once you have cancer spread to other parts of your body, I'm not sure that the waiting is that problematic because either way you end up on hormone therapy. So if we can delay the need for that hormone therapy, that's a win. It's probably not going to compromise your overall survival, but we're not in a curable situation anymore at that point.
I wanted to point out kind of a fun historical thing from the group. Lyle LaRoche, one of the founders, always wanted us just treat the tumor, stop with treating the whole prostate, stop with taking out the prostate. And he was a big proponent. He used to take me to dinner and yell at me about why are we treating places. I said, you can't tell, you can't see, we don't have data. And the Century trial is the first step to what Lyle had dreamed about of treating the tumor and trying to eliminate it. Because if the urologist could just pluck out a little tumor, or we could just target a little tumor, side effects would just plummet. So I think this is this could be a game changer if we can show the dose to the rest of the prostate goes down safely. That would be a game changer. And even though Lyle's not here anymore, I can still think it's not good enough. Why are we not? Can't do his voice, but it is a step in that direction.
Anyone have a hard stop? Do we have another still 5-10 minutes at least for questions? Okay. And one thing I wanted to have perhaps Dr. Rose touch on, I know you said that sometimes in patients the PSMA scan isn't showing all the cancer, but I think I've even heard that for some patients it never shows any of the cancer. Is that true? Can you comment on that?
That's true. Actually, I'll pass that over to Dr. Seibert. He's done a lot of work on imaging. So, Tally?
That's true because the problem with PSMA PET is that it depends on expression of PSMA. PSMA is just a protein that's on the cell. So if you're not making that one, then it won't show up. And so there are some prostate cancers that do that. They're not very common. It's more of a problem in patients who've had a lot of treatment and the cancer has evolved in the setting of all that treatment has changed and now it's not showing up. So it's not a big concern in the initial phase. That said, in the prostate, I wouldn't rely on PSMA PET alone. I would use MRI. I think that there's some evidence that PSMA PET on top of MRI, the two together is better. And so I like to use both, but the MRI is the best anatomy for it, showing you anatomically where it is.
And if that PSMA PET is it working in addition to the MRI, do you suggest going back to anything like an Oxyman scan?
You can. There are rare instances where that would be helpful, but they're very rare, so I wouldn't think of it as a first go. more likely is that the cancer gets really, I don't want to say weird's not the right term, but like we call it dedifferentiated, means it doesn't look at all like prostate anymore. It's very, very abnormal and might become something called like neuroendocrine. At that point, you probably need to use a standard PET scan, an FDG PET, like you would use for lung cancer or whatever.
Hey, first, thank you all for this very informative and a little bit overwhelming information. My head is exploding here. Now, I have many questions. Thank you, Dr. Rose. 8 years ago, you were my radiation oncologist. I'm a Kaiser patient, and I'm extremely interested now in the radiation therapy for my spine for what I have is many problems, not only osteoarthritis, stenosis, osteoporosis, and I've got a gazillion questions. I don't want to ask Dr. Google, as I always do. I want to know, as a Kaiser patient, do you think I could get another referral for a consult with you?
Oh, yeah, I do the
Either
arthritis.
one of you guys.
So I'm going to hold the arthritis to after, and if there are any group of people want to talk about arthritis, I'll stay after and do it. But yes and no, spine is tricky because spine often has a mechanical reason. Bones are sticking out, openings of nerves are narrowed. That won't help that. It's the sweet spot is like knees and hips and things, but spine can help, and we could talk about whether it would. But we'll go back to the. I'll stay afterwards and talk.
I want to thank you for excellent presentations, all of you across the board today. Amazing. More than that, I want to thank you. I want to thank you for your life commitment because it's a rough road you guys have been on. So thank you. 2 questions. One is there any evidence of environmental considerations here? Like, I don't know if you've heard of earthing or grounding. If inflammation is an underlying contributor to neoplastic disease, might inflammation or the reduction of it have some salutary benefit here, number 1. And then number 2, what about seeding from prostate biopsies? Is there any risk to that? I'm Gleason 7, I've had 2, and I'm a little concerned about the possibility.
I think the closest to our environmental expert is Brent, with the he's done work on Agent Orange and risk and different things. So can you try to do the environmental?
Yeah, I'm happy to talk about it, but I think before we talk, we have to kind of admit our humility that there's a lot of things that we don't know. There certainly are some exposures that are linked with prostate cancer. By far the biggest risk is just aging and being African American. Those are the big ones that everyone knows about and clearly are linked. There are some other chemicals like Agent Orange may have an increased risk, and Dr. Seibert's done some work on that as well. But there are not a lot of smoking guns out there for prostate cancer. We don't necessarily know. There's often chronic inflammation in the prostate gland, and whether that predisposes to prostate cancer, we're not fully sure. Likely there's some component there. There's really just a sort of a lack of data in this space. And so I wish that we knew more. Earthing, grounding, and things along those lines. We don't know much about. I had one patient that was doing it, and he had a fantastic outcome. But I don't know if that was the immunotherapy he had for a different disease, and we don't know. Do you want to introduce earthing and grounding?
Oh, grounding. It's about they're saying that the worst public health contribution of the last century is in the soles on your shoes. We should be walking around barefoot, having contact with mycelium and all that. You might. About how we walk as a reduction for inflammation. Carlsbad, guys, lights, come out, hurricane or grounding.
Yeah, I don't know enough about the scientific background to know exactly the proposed mechanisms of things along those lines, but certainly there's a lot of benefit to being sort of present in nature and that sort of centering yourself. And likely there's some connection between those things and earthing and grounding, but we don't know enough to comment.
Going out and walking is good for you for sure. Shoes are fine, but you should go walking.
Hi, I have a question, one for Dr. Seibert and then one for all of you. Dr. Seibert, I know you may have a little different take on spacer use. Could you expand on that? And for all of you, do you have any feeling about the PROSCAR test and its effect on which radiation you might choose, whether it be Dr. Rossi's stuff or Dr. Rose or Dr. Seibert's? Thank you.
Spacer. So Space OAR is one particular brand of a spacer. There are a few out there, Barrigel, for example, and they all do that same thing of causing that space in between. My personal view is, there's some pretty weak evidence that it's useful. It makes some logical sense. But at the same time, you are doing an invasive procedure that also it's very safe, but it has some small chance of side effects. So what I usually tell patients is up to them. If the one thing that it showed to do was better when in the trials it showed that compared with or without spacer, you'd see less diarrhea, which is great, but also would I have somebody putting needles into me in my perineum, down in that area so that I can prevent taking Imodium for a couple of days? No, right? That's not a great deal. So what you really are asking, what you want to know is, does it reduce the chance of like a rectum damage, like a bleeding or something down the road? Fortunately or unfortunately, so the good news is, because of the improvements in radiation technique, we've reduced the chance of anybody having bad rectal bleeding to a very small percentage. So that's really good. What that means is that it's very difficult to improve on that. So if it's 1% to 2% of patients that have really bad, rectal bleeding problems that require a procedure to stop it, then proving that you've reduced that 1% to 2% to what, 0.5% or something, would take an enormous trial and many years. So it'll never be done. So we're stuck with what we're stuck with. There's some logic to doing a spacer.
And there's particular logic, I think, in the proton world, because the angles of the beams are coming right once you.
Yeah. We started using the hydrogel in January 2018, and the rate of rectal bleeding, which is due to rectum that gets irradiated, has dropped, not just at our facility, but the other proton centers that are doing this. We used to see this in 20 to 25% of the patients, and they would typically report it beginning about 9 to 12 months post-treatment. And with the exception of those who are on blood thinners, it was self-limited and it wasn't a big deal, but it's still annoying. That number now is less than 5% because if you look at the dosimetry, we're able to reduce the radiation dose to the rectum by roughly 70% in our patients by using the spacer. But I think the other place that it's going to play a role is in the intraprostatic boosting. So, Dr. Seibert showed the data from the FLAME trial, and there was another trial, the ASCEND-RT trial, which used a different technique to boost. In either case, there was an advantage to it, and something that we all routinely do. But if you look at the location of the dominant prostatic lesions, there's a very significant percentage which are going to be in the periphery of the gland, very close to the rectum. And having the spacer, whether it's hydrogel or Barrigel, can allow you to deliver a substantially higher radiation dose to that area than otherwise would be the case, because you're not exceeding the rectum's tolerance dose of radiotherapy. So that's why I think it has another very useful application.
Thank you all for your presentation. I'm pretty lucky. This is my first time here, and to get you guys at that time, it couldn't be better.
You gonna come back?
What's that?
You gonna come back?
Oh, you bet. My question is, I'm kind of on the fence, and I'll tell you why. 7 years ago, almost 7, I had a radical robotic prostatectomy. My Gleason scores were 3.3. I had 1.34. My doubling rate was a little more than 2 years. I just had a recent MRI, PET scan, all showed no uptake. But now they're ready to do radiate the bed. My father was 65, had a radical prostatectomy, died at 89 without any further intervention of prostate cancer. So my question is, they're telling me, we'll do this, and you get a 50% chance of cure. I'm like, and 7 weeks of radiation, 5 days a week, and why a 50% chance of cure? 0.19.
Well, we said you can, generally our rule is wait till about 0.2 to 0.3. So you're knocking on the door, but you're not quite there. So I would, we don't know all the details and everything, but generally that's okay. Why 50% chance of cure? Because the cancer, PSA means that you have cancer if you've had a surgery, but you don't know where it is. So if it's in the place where we shoot, then there's a good chance that we'll kill it. If it's somewhere else, then the radiation's not going to fix it.
Okay, so that's where the 50% came from. All right. Thank you.
We don't know the details of your case, but 50% sounds very low.
Yeah.
Okay.
Especially for the story you just told.
Yeah. Prostatectomy a long time ago, a little bit of Gleason 7, and a very low PSA should be a highly curable situation.
All right, one from the back room here.
Again, thank you for your time and your energy, and it's been great. So, short background, 15 years on active surveillance, the last 5 years with UCSD and the great doctors there. My question is, are there any of you that would do radiation therapy without any hormone treatment at all? Or is there a study going on to where patients elect, or can a patient elect not to have hormone therapy? Would that be something you do?
Well, we do it all the time. Yeah, so not every patient requires adjuvant hormonal therapy. There are certain groups that benefit from it, and there are others where the benefit is so infinitesimal that the side effects of therapy aren't worth giving this to individuals. So that's the first thing you would need to know. And the other, of course, is when we recommend hormonal therapy, it's not like, well, if you don't take it, there's the door, head out of it and go someplace else. It's a discussion you have to have. And we all have it. How many times a week? Right? Because, seriously, it's a way to, if you look at it from the medical side, this is a way to push the odds more in your favor. And, in the cancer game, we all want to cheat. We don't want a fair fight. We want to do what we can to win. But quality of life is important, obviously. I can't tell you what your quality of life is. I can't do a test and give you some metric. And all of us have patients who we'll be looking at their medical data and saying, you really need to do this for XYZ reason. If somebody says no, you still treat them. You want to make sure you have the conversation as to why this is important. And perhaps, well, look, don't just reject it out of hand, but maybe start it. Do something that's short-lived, whether it's a 1-month Lupron shot or using Orgovix, which has a shorter half-life, to see how you tolerate it. Because you also find that while hormone therapy definitely causes problems, no doubt about it, people have issues with it. If you read online, you tend to read the patients who are posting are the ones who've had the worst experience. That's just natural human nature. It's a bell curve. You get a lot of patients who will tell you, yeah, I'm fighting my way through it. And lastly, while the gentlemen don't like the idea of being on it for 18 months, we still get off pretty easy compared to many breast cancer patients, where we use anti-estrogen therapy for at least recommend it, for a far longer amount of time.
How does the trial that I was talking about with the 6 months versus the 18 months, that's for patients with high risk prostate cancer. So that's very unlikely to be somebody who's on active surveillance. So yeah, we don't do hormone. And in those patients, then why do it if it's so awful? And I was saying, we want to avoid being on lifelong ADT. That's the reason. Why do it for 6 months? Why do it for 18 months? Because that's better than being on it for the rest of your life. But that's for patients who are at high risk of metastasis.
Can the androgen deprivation kill you before the prostate cancer? Because that's how you feel.
If you don't have a prostate cancer that needs to be treated, yes. If you have a prostate cancer that could kill you, then no.
And that's why I treated the arthritis of that patient, because he was on long-term and he was gaining weight and his muscle mass was going down. And I said, we got to increase the activity. He goes, these damn knees, how am I supposed to increase? So it got around, it sort of circled back to this idea of everything sort of comes together in this group. And I think hopefully we can limit the hormones to be shorter and more effective, not longer and more destructive, because they are so valuable in addition to radiation. We just want to make sure we do it correctly.
We're also testing newer drugs. Believe me, we're trying. And we have some stuff that's coming, I think, hopefully soon that'll be in trials that is a little different than what we've had for a long time. So.
All right, I know we've run pretty long, so let's just take one last question, but hopefully, I know that there's a lot of questions in the audience.
We have a woman asking. She take. Oh, we
And
have
there was a lady here
Oh,
too.
So two women
Let's do the
questions.
two ladies since we haven't had ladies ask questions, and then hopefully the
you're the
doctors can
advocate.
stick around a little bit longer to
We're gonna
answer a few more questions.
You can come up to us. Let's do the two questions.
Thank you so much for the presentation and for the panel discussion. A lot being thrown at us. My husband has had radiation and he's currently going through hormone therapy. You've talked about a lot of different options that are available now. Is he precluded from participating in anything new from a trial perspective?
Well, it's this tough. The details matter a lot. So knowing whether a particular patient is eligible for a trial requires probably an in-person consultation to look at the details. But I mean, there are trials for all kinds of things. And then what's available where and for which patients is pretty nuanced, unfortunately.
Did you guys want to take the one other question here? Or okay, last question, then we'll break.
I'm sorry.
I'd seen his hand.
He should send his too. He should get his.
Sorry. So there was a lot of talk about radiation for primary prostate cancer, and I have recurrent prostate cancer, and so I have sort of a few questions about that. One is, just to give it out to everybody, the difference in the side effects of treating primary prostate cancer with radiation versus recurrent. And then also genomic testing, immunotherapy, spacers, and this, I think it's called ultra hypofractionated radiation therapy. Do any of those apply to recurrent prostate
Can
cancer?
we hear a little bit about the recurrence? So some people recur just after surgery alone. Some people have lots of different things that recur. What is your situation?
Okay, so when I had, just before surgery, my PSA was 10. For 3 years after the surgery, my PSA was kind of oscillating between 0.01 and 0.02. When I moved to San Diego, it started gradually going up, and just recently it was 0.22.
Okay.
At about 9
So
years.
That's, you only had surgery.
Yeah, so far, yeah.
Okay, no hormone treatments or radiation. So there's lots of opportunities for you. It's just, the question is what should be done? I think we're getting to a point that something, the number's getting high enough, as we talked about in other people, that we should do something. But the question is what? The typical thing is if we think it's from where the prostate was, which is a likelihood, that would be a smart thing to target. But a very common thing is to nonetheless check with a PET scan, PSMA PET, to make sure it's not in a lymph node or it's somewhere else.
I've had an MRI and a PSMA recently, and they were negative, I believe.
Yeah, so it must be at such a low level of cells that it's somewhere, but we don't know where.
Yeah.
So it gets into a tricky game of trying to figure out when to do it. Traditionally, we would treat just your bed of where that was the standard approach. Today, we want to try to find, is it there or is it somewhere else, or is it there and somewhere else, is a tricky one. So I think at this time, it would be good to talk with your doctors about, as the PSA, let's say it's really slowly going up, then you have more time to figure things out. If it's shooting up, that would imply there must be disease in other places and so I think a really useful thing would be, don't you think, guys, PSMA PET at this point, but it might not show anything. But that doesn't.
I've had both.
I'm sorry, you had it, it was negative. And so it might need to be, watch the PSA, it might need to be repeated. Tyler, do you want to weigh in?
No, I agree. That's fine. I mean, if the scans are negative, then it's like we talked about with the other patients, that the best guess is that the cancer is where it used to be. So it's right in the neighborhood of where the prostate was. And we treat that with radiation. We watch the PSA and see if it's fixed.
Right, but, okay, but what about the side effects for primary versus recurrent?
They are similar. It's definitely, I mean, there's a higher risk of irritating the bladder and the rectum if you've had surgery, because you're not treating a prostate anymore, you're treating the space right between them. So it's a little bit higher, but it's not dramatically different. It's fairly similar. We can't do the 5 treatments option anymore. You have to come more times, but it's safe.
The dose is lower.
Yeah.
After the prostate's removed. So we're not going to this high level plus all that boosting and all these things. But that can help reduce the toxicity rate. But we still, do we know exactly where it is the hardest thing.
And yeah, so and my second question was, in my case, does genomic testing, immunotherapy, spacers, and this shortened treatment thing not apply?
Shortened treatment, no. Spacer, no. Genomic testing, yes. Immunotherapy, no.
So where would you get the material for the genomic testing?
From your prostatectomy. They go get it from the hospital that did your surgery.
Okay, I see. Yep. Thanks.
All right, great. Another round of applause, please. Thank you so much, doctors, for coming in and spending your time with us. It was a wealth of information and well received. Very, very thankful for your time.